Do I start now? Hello, organizers, do I start?
Yes, you can start, Doctor.
Okay, thank you. Hello, everyone. Good day and welcome to this skills building session, Health Systems Research Methods to Study Medicine's Quality and Use, Spotlight on Design, Data and Dissemination. Next slide, please. My name is Hazel Bradley, and I'm a senior lecturer at the School of Public Health, University of the Western Cape in South Africa, and I'm the moderator of this session. This session is being compiled by members of the Medicines in Health Systems Thematic Working Group, and we're really glad that you've joined us today. Next slide, please. I'd just like to start off by explaining a little bit about the structure of this session. We'll have a welcome as now and a few introductory remarks. And as you can see at the end of this, I put a poll because you will find at the on your screens there is a place where you can answer 3 poll questions, and we encourage you to start doing this now so that we can find out who else is joining us for the session. So the poll questions ask you 3 questions: which region you're from, you reside in, which sector you work in, and if you're a member of Health Systems in Medicines and Health Systems Thematic Working Group. So we really hope you'll answer these poll questions, and then a bit later on we'll look and see who else has joined us for the session. Then we'll go on to highlight the learning objectives for the session. After that, I'll introduce you to the 4 speakers we have lined up for today, and we're really glad that they're joining us to tell us a little bit more about the methods that they've been using to study medicine's quality and use in their own work and research. At this point, I'd just like to notify you that unfortunately our second speaker, Nondumiso Hube from Eswatini, is unable to join us today as she had a family bereavement at the weekend. So I will do her presentation on her behalf. Thereafter, after the 4 speakers, we will then have a question and answer session. And we hope that as participants of this session that you'll actively be engaging with us by posting your questions and answers as we go through the session today. And then finally, we'll have a few final reflections and a wrap up. So just a few tips on the platform. Some of you may have seen this already, but there is a support chat button if you need any support with any technical issues during the session. I've mentioned the Q&A session that'll be at the end of this Q&A at the end of this session. So please send your questions in the live Q&A section next to the screen and address the speaker by name if you can, so that I know who to pose the question to, or if it's for everyone, put that as well. And we'll be picking up the questions at the end of the session, as I say. There's other indications about how you can best view the session by using your full screen. Just to notify you that the session is recorded in case you miss anything. It'll be available to view tomorrow and onwards until March, and a few other instructions. So those are just tips on using the platform, which some of you may be already familiar with. Okay, let's move into the session more particularly. So poor quality medicines are a serious threat to individuals and public health, and they waste household resources as well as health system resources. And as well as that, poor practices in management and prescribing and use of medicines along their life cycle can both harm individuals and again, cause harm to the health system at various levels. So over the past few decades, several research methods have been developed to describe the challenges and test solutions to medicine's quality, supply, and use in different health system contexts. So in this session, we're going to provide you with some information about study design, analysis, and interpretation for decision-making to promote medicine's quality and efficient medicine's use. So I'd just like to go on and list the 4 specific objectives that we have listed for our session. The first one, provide an overview of commonly used health system research methods to study medicine's quality and use of medicines to inform policy and decision making. Secondly, identify data access. And thirdly, address methodological, ethical, and other challenges. And fourthly, to interpret data and translate findings into actionable policy and practice recommendations, particularly within the framework of universal health coverage to promote medicine's quality and use. So they are quite challenging objectives. Please bear in mind that when we started thinking about this skills building session, we were expecting to be able to engage with you face to face for half a day. And so because of this, because of COVID and the virtual platform, we're glad we've got this opportunity to present an abbreviated version. And we hope that you will gain something from this session, and we look forward to engaging further in more detail in subsequent engagements, particularly through the thematic working group. Next slide, please. So I'd just like to then introduce to you our first speaker this afternoon, or morning or evening. Raffaella Ravinetto. Raffaella is a senior researcher and policy advisor based at the Institute of Tropical Medicine in Belgium. She's a pharmacist and a PhD in biomedical sciences with a vast experience in global health, humanitarian programs, and academia. And her particular interest covers access to quality assured medicines, pharmaceutical systems, and research ethics. Raffaella's presentation is entitled Assessing Quality Systems in Pharmaceutical Procurement, the QUAMED and ITM Methodology. So welcome, Raffaella, and over to you.
Good morning, or good afternoon, or good evening. Thank you, Hazel, for introducing me, and thanks to the organizer who gave me the opportunity to present the methodology and some of the results of our work, which I'm also doing on behalf of my co-authors, Arianna, Gerlaine, and Anthony. I'm just going to quickly remind in which kind of environment we have developed our research. It is the current environment of a highly globalized pharmaceutical market with a very complex net of different intermediates, which is becoming even more complicated under the current circumstances of the COVID-19 pandemic. Unfortunately, this globalization of market was not accompanied by a corresponding globalization of regulatory controls or by an harmonization of regulatory overview. Therefore, the supply chain becomes vulnerable to poor quality medicines. Whether we are talking about substantial medicine or falsified medicines or medicines which degrades along the supply chain, this is always a great risk for individual health and for public health. And we were, when we planned this research, particularly concerned about the risks to quality at the intermediate steps of the supply chain. So distributors, wholesalers, import-exporters of quality of medicines and medical products. And thanks to the collaboration with QUAMED, we were in a privileged position to try to look at the quality system of these stakeholders, and this quality system are a direct indicator of the risks of quality, of getting poor quality medicines when you purchase medicines. QuaMed is a non-for-profit association. It brings together international NGO and African central medical stores. They all purchase medicines for either humanitarian or development of public health medical programs in low and middle income countries. And because of the poor regulatory supervision, they need to secure their purchase by trying to identify those suppliers which offer the best guarantee that they have a good quality systems and they will not be supplying poor quality medicines. To do so, very practically, QuaMed members, they pool resources for conducting independent audits at potential suppliers, and audits or technical assessment are carried out by according to the adequate standards as defined in these two WHO guidelines. QuaMed is not a regulatory authority, so these audits are carried out based on a confidential agreement with the audited distributors, and results by distributors are only shared within the network. But we also realized, even if we cannot share individual distributors' data, there are still some lessons learned from this experience by auditing different distributors across countries and over time. Is there any way that we can still share the lessons learned with a broader audience? And the answer was a sound yes. Yes, we think that we can do this. And we decided to carry out secondary research, kind of nested in the operational activities. And we also were so lucky to be able to publish this in the BMJ Global Health. To be a little bit more detailed on what we do, we have source data. Source data are the reports of the audits carried out by QuaMed auditors at licensed pharmaceutical distributors located in different contexts. We developed the research action model by which we start from these raw data, which importantly were not collected for a research objective. These raw data were just collected to provide to some purchasers information about the distributors to know whether the distributors is reliable or not in terms of quality. And we translated it. So here a researcher comes in the picture, and we translated this narrative information into a numerical indicator on a research rating system by activity. So each activity is defined in the rating system, is attributed a number from 1 to 4, where 1 means not compliant with adequate standards and 4 means compliant with adequate standards. Of course, there is an important effort needed for this translation. And then we publish our data mainly in terms of percentage of compliant distributors by activity. To make this is a little bit theoretical. Here we can see the list of these 17 activities which are derived from the WHO guidelines. The distributors which have a quality system which ensures quality medicines will comply with good standards and will have a level of 3 or 4 for each of these activities. We can take one specific example, the 5 activities which belongs to the macro area of storage and handling specific products. Here we will have a rating for each of these: the warehouse organization, the adequacy of physical storage condition, management of cold chain, stock control, and handling non-conformity. By applying this methodology, we have done 3 research works up to now. In the first one, we assessed quality system of African central medical stores and international humanitarian distributors. So all distributors which are also importing and exporting. And we have found elements of concern, significant weaknesses, particularly in the initial selection of medical products and in their continual reassessment over time. We then had a look at the private sector, so at 60 private distributors in different low and middle income countries, acting locally, not importing or exporting. And we found also serious weaknesses, particularly concerning the compliance with good distribution practices and also with the cold chain management, which is essential for quality of vaccine and other products. In the more recent work, we pulled together the big and the small distributors, sorry for the lay language here, and with looking at more recent data, and again we found a number of weaknesses at different levels. To put it short, there was not a single distributor which was complying with all of the 17 activities which were rated. What can we learn from this experience? Well, firstly, we have learned that there is not an approach which fits all the kind of distributors. We want to rate distributor active in the international market. We have to make a difference between those who are also importing and those who are not importing. We have to develop two different rating systems. More important, we have to make a bridge between the pharmacy, so the technical auditor, and the research in public health. Auditors are not only the ones who give us source data, but they must be actively involved in the development and the assessment of the research rating, which translates their work. This must be tested in a very rigorous way. And we also acknowledge that there is a limitation we cannot mitigate. Even if all the operational and research tools are nicely standardized, there is a human element. The initial audit is done by a human auditor, and there can be some subjectivity which cannot mitigate. But then we have two more important and general messages, on which I will conclude my presentation. The first one, this evidence from audits, from routine activities, can generate generalizable knowledge to inform regulators and policymakers. And this is very important. We just collected initially this data to tell an African central medical store and NGOs, you can buy from these distributors, take care, I would not buy for that one. But then by putting together and aggregating our results, we have been able to focus on specific problem by sector. We can be able to say this specific activities is weaker in this sector, in this level of the health system. So this can really inform the policy makers and the regulators. And we would like, for this reason, really encourage other people who carry out such kind of operational audits to do the same translation process, because this information can become very informative at health system level. And to my knowledge, for instance, a couple of years ago, the Brazilian regulatory authority made a very nice publication in PLOS, a little bit in this line. The second and last message is that doing this research is not only a nuisance to the auditors. Initially, the auditors said, oh my God, we are doing our work for very practical reasons, and now people from public health are coming and they want us to do extra work, and we don't really see the reason. And in fact, apart from informing policy makers, going through this process of bridging between guidelines and research by creating a research system, rating system, by translating the audit results into research, we were able to give a feedback to the auditors and to tell them, listen, there are some of the activities that we cannot, for instance, nicely assess because the way you are collecting your information is useful on case by case, but we cannot really aggregate it. We cannot really put them together. And so we started working together, and the auditor data collection tools have been updated as a result of the research auditor. So we are also managing to create a bridge in terms of language between the world of pharmacy, of the auditors, and the world of public health, and they are starting to talk to each other and say, okay, perhaps we have something we can really do together, because we have different language, different tools, and the same objective, which is to ensure that quality assured medicines are available through the health systems. 12 or 13 minutes are really short, so I have to close here. For those who want to understand more, here you find the links to our open access papers in the Global Health, the BNJ Global Health. You can also find the website of QuaMed to know more about this innovative associative platform. And I want to thank really a lot all the colleagues who makes this available, with a special thanks to our Belgian colleagues from the DGD and from Because Health. You don't know them, but they were very key in starting the whole process around QuaMed and this work. And I thank you very much again for the opportunity to share all this. I give the word back to Hazel.
Thank you very much. Thank you very much, Raffaella, for this really amazing work that's been going on for a few years now, looking at quality of medicines, and really in your presentation showing a clear link between research and policy. So that's really great. And I'm looking forward to questions and that people were going to pose to you. So please remember to use the Q&A function to ask questions that you would like to point to Raffaella, and please put Raffaella's name if it's not obvious that it's to her. So thank you very much for this opportunity to now move to the second speaker. So the second speaker was going to be Nondumiso Ncube, who is a PhD student from Eswatini and currently studying at the School of Public Health of the University of the Western Cape. As I've just mentioned at the beginning of this session, unfortunately, Nondumiso is not able to be with us today, so I will be presenting the presentations she's prepared to you. Myself and Richard Lang and Helen Schneider are supervisors for Nondumiso's PhD. So I'm going to now share my screen with you and share the presentation. Thank you. So the title of Nondu's presentation is Improving Facility Use of Medicines Using Mixed Methods, a case study of Eswatini. So in this particular presentation, we're going to be focusing on the use of mixed methods as suitable methods for looking at medicines use. Oh, I can't seem to move to the next slide. Oh, sorry. So Eswatini is a landlocked country in southern Africa. It's a small country with a population of just over 1 million, and not very much is known about medicines use in the country. Eswatini, it was formerly called Swaziland, for those of you who are not aware. So Nondumiso looked at medicines use in Eswatini as part of her PhD research, and what I'm going to share that with you today. So this study used mixed methods study design. It was a mixed methods pre and post intervention study conducted to assess particularly prescribing practices in public sector and faith-based facilities in Eswatini. So in Eswatini, the majority of the population access their healthcare through these public sector and faith-based facilities. The study was conducted in 3 phases, a baseline survey, an intervention section, and then a post-evaluation third phase. And like I said, it used both quantitative and qualitative methods. So the quantitative component used the WHO inward prescribing indicators, and I'm going to explain a little bit more about that in a few minutes. And then the qualitative component comprised semi-structured one-to-one interviews using an interview guide informed by social practice theory. And these were particularly to key stakeholders in the Ministry of Health at various levels within the health system and the central medical stores. So just to tell you a little bit more about what the quantitative data collection. So rational medicines use is a concept that dates back to about 1989 with the establishment of the INRUD group. So INRUD stands for International Network for Rational Use of Drugs. And one of the key sort of contributions of the group was the development of indicators that have become standard WHO indicators over these years. There are three sort of main groups of indicators: prescribing indicators, health facility indicators, and patient care indicators. And these indicators have been widely used, mostly in low middle income countries, but also in some developed countries too. And yeah, quite a lot of publications have been are available in which these standardized indicators have been reported. So, and I say a key contribution was of this INRUD group was the development of the indicators, but also a manual. And this manual was used by Nondumiso to provide guidance on conducting her particular study. And it's called How to Investigate Drug Use in Health Facilities, and it's available as an open source tool, and there's a link here to it. So this particular methodology is useful to compare medicines use patterns between prescribers at different facilities, between facilities within a district, or province, countries and regions, and also to compare over time and or pre and post intervention, as was used in this particular study. So the indicators, because they have been standardized, are very useful tools. So just to emphasize again, what is the value of using a mixed methods to study medicine's use? Well, the quantitative methods provide obviously the quantifying aspects of medicine's use, which are useful to when we're thinking of interventions, and we can then measure change over time, or change pre and post. The qualitative methods really help us to understand some of the reasons behind medicine's use patterns. And because of that, they can also guide us into how we can design interventions and which interventions might work and assist in improving medicine's use. So combining these two approaches, they help to give a comprehensive picture of medicine's use patterns. And like I say, guide us as to what sort of interventions would be useful to improve medicine use. So just going back to Nondumiso's study, again, in the manual, there is guidance on sampling methods that are appropriate. There are papers that have been written too about that. And in Nondu's particular study, she used a two-stage randomization process in which she randomized facilities from, as you can see, the 4 different regions in Eswatini. And then she also randomized 100 prescriptions from each of the facilities. Her analysis, the quantitative analysis, included sort of more of a descriptive analysis, and then also more analytical analysis, which was used, in which Stata and SPSS were used, packages were used. The qualitative component, for the qualitative component, she used thematic coding analysis, and her particular software, she used Atlas TI as her software, but obviously you could use others. So this just gives you a little idea of some of the sort of results that you can gain from using these type of INRUD indicators. So you will see this slide is a little bit busy, so I'll just explain it a little bit more. Nondumiso collected information at 3 particular time points. Baseline in blue, post-intervention in orange, and post-follow-up is shown in gray. So at 3 particular time points. And then you can see that she has displayed in this particular graph 5 different indicators. Average number of medicines on each prescription, the percentage of generics that was medicines that were prescribed by generic name, the percentage of prescriptions that contained 1 or more antibiotic, the percentage of prescriptions that contained 1 or more injection, and the percentage of medicines that were prescribed from the essential medicines list or formulary. So this just describes these 5 particular indicators. And then you will see in the box, she's listed the optimal values as recommended by WHO. And you will see those in the corner, in the column on the right hand side. So if we look particularly, say, at the middle particular indicator, percentage of antibiotics, we can see that at baseline, in the purple, there were 54% of prescriptions that contained at least 1 antibiotic. That's over half of the prescriptions contained at least 1 antibiotic. After the intervention, it went down slightly to 49%. And then post follow-up, it actually went up further even than from the baseline to 57%. So that's an indication from the quantitative data of what happened during the course of the study. If you look at the table now, and the middle line says that gives the indication that the optimal value for percentage of prescriptions that have 1 or more antibiotic, the WHO recommend less than 30%. So you can see that this gives an indication that in Nandu's study, the percentage of antibiotics used was above what was recommended by WHO. So you can also obviously, compare with the other indicators and the WHO values. So this is just the results, some of the key findings that Nandu had in her study, that although when she did the more analytical statistical analysis, although significance was not reached, although not reaching statistical significance, there were small changes documented immediately post-intervention. So the intervention did have some sort of impact, but as she says in her final bullets, most of these changes were not sustained at the end of the follow-up period. And a couple of key things that came out that really struck Nandu from the overall results were that there were high levels of polypharmacy, that is lots of items per prescription, and high levels of antibiotic prescribing across all the regions. This is why I highlighted that particular indicator. An interesting previously unreported finding was that antibiotics were frequently prescribed for chronic non-communicable conditions. So this was a very interesting factor, and in fact, this finding at the baseline was something that guided Nandu as to how she should target her intervention. So that was again another use of the quantitative data. The qualitative data, again, like we said, the qualitative data helps to, give information as to why some of these things are happening, and point towards, possible reasons. And what Nandu's findings really highlighted, that there were a lot of, it was a complex situation, and there were numerous sort of multifactorial sort of reasons for some of these findings that emerged. And so she's classified them as material, provider-related, and patient-related factors. Some of the material factors included poor use of standard treatment guidelines, for example, and there's a link there to a paper that was published detailing these in a bit more detail. So finally, in summary, so this research sort of was able to conclude that there is irrational use of medicines in Eswatini, particularly in the public sector and government facilities where most people access their medicines when we assess against the WHO standards. Using a mixed methods approach, both using the quantitative inroads sort of indicators plus a qualitative component gave a sort of comprehensive picture. And together they really helped to assess what the situation is in Eswatini, to guide an intervention and then to measure the follow-up. And this whole study really provides a good basis for working further with the Ministry of Health in Eswatini in order to improve medicines use in the country. And I'm pleased to say that Nondumiso is now back working in Eswatini, her home country, and she is actually working, looking at antimicrobial stewardship at national level. So she is now in her own work applying some of these principles that she was, some of these methods that she was involved in this study, which was her PhD. That's all from me. Thank you. And Nondumiso's contact details are at the bottom of the presentation. And so although she wasn't able to be part of the presentation today, if you do have any other queries, you're welcome to contact her on that number. Thank you very much. And I would like you to encourage you to post any questions and answers that you have in the Q&A function. And I'd just like to tell the organizers that I'm not able to see any of them at the moment. Maybe, okay, I need to change it, my function maybe. I'd like to move on now to our third speaker, and I'm very glad to welcome Zana Kiragu. Zana is from Kenya. She is a research fellow and a Doctor of Public Health student at Boston University School of Public Health. Zana is a Kenyan pharmacist and public health professional. And as I say, she's currently working as a research fellow at Boston University and also pursuing her Doctor of Public Health in Leadership, Policy and Management. She has particular interests on affordability and availability of quality assured medicines in resource limited settings. And the title of Zana's presentation is Evaluating NCD Medicines Access at Household Level Through Phone Surveys. Zana, it's over to you.
Thank you very much, Hazel, for that introduction. I'll just go ahead and share my slides. Thank you, everyone, for joining us today. As Hazel introduced, I will be speaking about studying access to medicines at the household level through phone surveys. So I'm going to start by giving a general overview of the method, and then I'm going to go ahead and demonstrate its application through the work that my colleagues and I were engaged with at Boston University. So to start with, as you can see in this figure here, the ownership of mobile phones has drastically increased in the past 10 years or so in low and middle income countries. And this presents clear rationale for the use of mobile phone surveys for data collection. In addition to that, there's a systematic review that was undertaken in 2017, which reported there were 19 mobile phone surveys used for data collection in low and middle income countries. and across various continents. Of note here for our interests in medicines was that none of these mobile phone surveys collected data on medicines in the household. There are many types of phone surveys, and the most commonly used phone surveys in low and middle income countries are voice calls. There are also computer-assisted phone interviews, or CATI, which is a voice call that is administered by a data collector, and the survey responses are recorded in a software program, as well as text messages. Other types of surveys include interactive voice response, which is a programmed computer survey, unstructured supplementary service data, which involves the telecommunication company in communicating with respondents, and the wireless application protocol, which requires wireless network. So some of the factors to consider when determining what type of phone survey to choose include the costs of the phone survey, the type of respondents that are engaged in the study, the type of study, and the type of questions being answered, as well as the length of responses you require from your respondents as well. Some of the benefits of phone surveys for data collection are, to start with, it makes it possible to collect data in inaccessible areas or difficult to reach areas. It's also a quick response mode of data collection. There's a high degree of flexibility with short turnaround times. It's cheaper than in-person phone surveys and potentially has better storage as well for data. There is also flexibility with the types of languages or the number of languages you can use to administer the surveys. There are some downsides, however, to using this mode of data collection. It does require a reliable network coverage, and it also does require high cell phone penetration rates. As you saw in my first slide, it is relatively high in low and middle income countries. And the data collectors are unable to observe the respondent's body language, so we lose that aspect of nonverbal cues in collecting data as well. We may also lose respondents if they lose track of their mobile phones or if they change their phone numbers as well. Lastly, it's not possible for data collectors to confirm the responses that have been fed in through a phone survey once the data is reported. Bearing these in mind, there are some methodological considerations for the rollout of phone surveys. And the first point to think about is sampling. You could go about it in two ways. You could undertake an in-person baseline survey and collect phone numbers from respondents that way, and then following up from then on, administer the survey via the phone calls. You could also randomly dial phone numbers and establish which respondents meet your inclusion criteria and sample in that way as well. Response rates are another thing to consider. Response rates for phone surveys are typically lower than in-person surveys. However, they are relatively high. Another thing worth thinking about are incentives. There is mixed evidence on the effect of incentives on response rates in low and middle income countries. And so it is worth considering the cultural context within which you're working as you determine whether to involve incentives or not, and which type of incentives to include. Another issue that's extremely important is the validity of the data. And here there are two pieces. First, there's selection bias. As I mentioned, we need to think about the network coverage and penetration of mobile phone ownership. In the event that you're undertaking a study in an area where there is poor network coverage or the mobile phone ownership is not as extensive, you would end up recruiting respondents that may not be representative of your underlying population. Another thing to think about is that the data cannot be verified as it is reported via the phone survey. And a way to bypass this is to overcome this is to undertake in-person validation visits for a subsample of your study population to determine if the responses they fed through the phone survey match what they say in person. Some ethical issues worth considering are patient confidentiality, ensuring that the patients are in a position to engage with the phone survey as it's being administered, and that data collectors, if they are involved, are in a position there where they are not compromising the patient's confidentiality as well, in a secluded office, for example. It's important to engage local leaders in the community that you're administering these surveys, even though you will not be physically in the community. And appropriate language is extremely important as well, considering we lose the nonverbal cues. So we need to make sure the respondents clearly understand what is being asked of them. Lastly, the length and frequency of these surveys are important to consider, and as this will affect participation. So in sub-Saharan Africa, these surveys are typically 15 to 30 minutes long. I will now jump ahead to the case study. This is an example of how phone surveys can be used, and this was in the evaluation of the Novartis Access Program in Kenya. So just to set the scene a little bit, as you can see here from this data from the Communications Authority in Kenya, mobile phone ownership in Kenya is quite extensive. It's high penetration, which tells us that this is a suitable location or a feasible location for administering mobile phone surveys. And some background on the Novartis Access program. So Novartis Access was a low-cost medicine program targeting 50 medicines for 4 non-communicable diseases. And Boston University was engaged as an independent evaluator for this program. So this evaluation focused on the impact of Novartis Access on the availability and affordability of NCD medicines at health facilities and households in Kenya. The study was undertaken in 8 counties, which are shaded here in this figure, as you can see, and it was designed as a randomized controlled trial. So 4 of these counties were randomized into the control arm, and another 4 were randomized into the intervention arm. This here is a timeline of the Novartis Access evaluation, just to orient you a little bit better to how phone surveillance was used. As you can see, the baseline data collection started in September of 2016, and this data collection was in person, where phone numbers of respondents were collected. Following this, the program was launched in the intervention counties in November of 2016, and phone surveillance began in December of 2016 with a random sample of 400 households. We did engage validation visits as well between December 2016 and December 2017, where 10% of the households in surveillance were visited within 24 hours of the phone interview to confirm the responses that they'd given over the phone. And so there were in-person visits at baseline, midline, and endline, with phone surveillance being undertaken throughout the study period. So some key considerations that were very crucial for the success of phone surveys for the Novartis Access program, as reported by our research coordinators and senior field officers, was to start with having a very clear, robust survey tracking system. And so we use the CATI, or the computer-assisted technology, for phone surveys here, and the responses were fed directly into the robust data system survey CTO. They also engaged the local community in the use of guides to draw samples from the regions to ensure that they were engaging people that they were able to maintain continuous contact with. Prior to the start of making the phone calls to respondents, they sent out text messages to resensitize the respondents and reintroduce the organization and explain the purpose of the phone surveys as well as the survey duration. And the surveys were designed to be quite short, at about 20 minutes long. There was also a clear consent process for each phone call that was made to respondents. And in addition, the data collectors made sure they scheduled appointments with respondents to make sure that they were available to speak about their medicines. The interviewers or data collectors are properly trained and very well versed with the data instruments, and they were maintained throughout the study period as well. So the respondents became familiar with them as well. Each data collector was given a unique call list with each of the respondents' details to make sure that we were not duplicating and calling more than one respondent in a given month more than one time. So in addition to that, the data collectors would take frequent breaks between calls to make sure that they were not getting too tired or making mistakes with the phone calls they were making. Lastly, appropriate incentives were used to appreciate the respondents' time. Some of the challenges that were faced in the field in the implementation of these phone surveys was, to start with, network coverage was poor in some areas, and here the village elders were extremely crucial in helping to track the respondents. Language barriers and illiteracy were another challenge, and the language barrier was preempted by engaging or hiring data collectors who are fluent in the languages in our study areas. And as far as illiteracy went, there was use of text messages to follow up with respondents if they were unable to read the medicines list, or until they were around somebody who could read the names and forward them to the data collectors. In the event that the people were not at home at the time they were called for the phone survey, text messages were also used to follow up on the medicines list. There were some communities in our survey that were nomadic as well, and this means they would go out and look for pastures for their cattle. And here, what the data collectors did was they made multiple call attempts and sent text messages towards the end of the month when these respondents were likely to be back in their homes where there was better network coverage. There was some migration outside our study areas, and here the village elders helped us track whether people had left the study area or not. And we did have some attrition over time, as it was a relatively long study period. There were some refusals to participate. Lastly, there were some safety issues with ethnic clashes and banditry, meaning that there were times some respondents were not able to be reached. So just to show you a brief snapshot of what can be done with the data from phone surveillance, this here is showing the availability of NCD medicines by intervention. As I mentioned, this was designed as an RCT. So, and availability here was defined as having at least one medicine for each of their NCD diagnoses available at the home at the time of the phone call. As you can see, there is not much difference in availability across the study period between the control and intervention counties. For more information on the evaluation of the Novartis Access Program and the report on the findings from the randomized controlled trial, my colleagues did publish in the Lancet, and I've shared the link here in case that is of interest. There is also a website evaluating access at the bu.edu site in case you're interested in learning more about the study design and the study protocol as well. In addition, we had a webinar in September as part of the Medicines and Health Systems Thematic Working Group, where I presented alongside my colleagues Paula Shigby and John Boyer in much more detail on this method. In case that's of interest, I've shared the link here. And lastly, there is the systematic review giving some background on the use of phone surveys in low and middle income countries, in case you would like to learn more about that. I'd like to thank my colleagues, Paul, John, and Mungai, who were very instrumental in the operationalization and implementation of this program in the field, Richard Lang and Veronica Ritz, who were the principal investigators, and Peter Rockers and Monica Onyanga, the co-investigators of this research. Thank you very much for your time. I'll hand over to Hazel.
Okay, thank you very much, Zana, for that very comprehensive and detailed presentation, which really showed us how telephone surveys can be used to look at medicine use, and yeah, very interesting results too. So thank you very much indeed, and hopefully there'll be some questions for you a little bit later. We haven't had any too many questions at the moment, so please do post your questions if you have any for the speakers. It will be great to have some sort of interaction towards the end. And now I'd like to introduce our fourth speaker. Our fourth speaker is Samuel Aruba. He's a postdoctoral associate from Nigeria, and he's currently working at Boston University Institute for Health Policy and Innovation and the Department of Medical and Biomedical Engineering. So Samuel is a pharmacist with a PhD in clinical pharmaceutics and 16 years experience in academia, hospital and community pharmacy practice. He's interested in pharmaceutical public health, including access to medicines, pediatric formulation development, medicines quality, and antimicrobial resistance. And I'd just like to invite Samuel now to give his presentation, which is entitled Consumers' Perspectives on Medicine Use and Quality, using Structured Observation. So Samuel, welcome, and over to you. If you can.
Yeah, thank you, Hazel. Hello, everyone. I know we're in different parts of the world. We have seen so far research focused largely at the facility level. In this part of the presentation, we're going to look now at research focused on the consumer perspective. So give me a minute to share my slides. Hazel, can you see my slides? So the title of my presentation is Consumer Perspectives on Medicine Use and Quality, Structured Observation. The story is told in my part of the world. I'm originally Nigerian, of a patient who, when it was pointed out to him that he needed to shake the bottle, started jumping up and down quite vigorously in order to shake the medicine he has just taken. Now, this anecdote is a somewhat benign example of the consequence that could happen from the unintentional use of a drug, highlighting the importance of understanding the context and the use of the drug. As you can see on the outline, I'm going to give a brief overview of access to medicines and how acceptability and quality are also important access dimensions. We'll look at what structured observation is, then we will go on to case studies concerning medicine use, quality, and then finally, the considerations for conducting a structured observation. Access to medicines in health system is composed of 5 dimensions, and these are acceptability, geographical accessibility, availability, affordability, and quality. Notice here that we've highlighted acceptability and quality. Acceptability has various definitions. One of them by the World Health Organization is that acceptability, or in this case, satisfaction, is the relationship between the user's attitudes and expectations about the product and services and the actual characteristics of the product or services themselves. The second definition by the European Medicines Agency defines acceptability as the overall ability and willingness of the patient to use and its caregiver or carer to administer the medicine as intended. Consumer acceptability impacts medicine's use, and this could be adherence, as in the case of an adult, or ease of administration, as in the case of a child. Hence, there is the need to integrate acceptability early on in product design, preferably phase 1 clinical trial stage. However, the challenge is that there is as yet no standardized methodology for evaluating acceptability. What is structured observation? Simply put, this is observing events using a guide prepared in advance. These events in the context of this presentation refers to behavior, but it can also mean perspectives or other such events. It is structured in the sense that in terms of location and data collection, it has to be rigorously designed and implemented. The location is usually that in which the event naturally would occur. It is most often a cross-sectional research design for primary data collection using the guides here, in this case, checklist. We will move on quickly to look at case studies and considerations in the design of structured observation. These case studies, one of them has been performed, the second is proposal. They're both located in Nigeria. In the first one, which we captioned learning from the mouth of models, this is essentially reflective of the importance of capturing consumers' perspectives and also understanding the context. The background to this is a proposal by the WHO of flexible solid dosage forms or flexible solid oral dosage forms as a preferred formulation for children. Now, the background to this policy proposal is based on an expert panel recommendation, which are in turn based on certain carefully thought out clinical, technical, and economic perspectives. As part of my PhD, we wanted to understand or generate evidence at the end user level for this proposal. So we designed a holistic study. One part of this was to prospectively perform a cross-sectional study to assess acceptability and preference. The data we sought to collect related to acceptability, we had 3 measures for that. You can see the details in the paper. So here I'll just quickly provide the highlights. For acceptability, we use level of liking using a 3-point Likert scale, as well as ease of administration for 10 different oral dosage forms as listed in the essentials in the British National Formulary. For preference, we asked participants to rank their dosage form of choice. Acceptability also included ease of administration, where the outcome was binary, with patients saying they found, particularly now, in this case, the dispersible tablets. They found the dispersible tablets, which is the WHO flexible solid dosage forms, whether they found the dispersible tablet easy or difficult to administer. For preparability, what we wanted to do, using now the very specific structured observation approach, was to see really whether the consumer stated ease or difficulty of administration or preparation actually was reflected. So we wanted to use a checklist to see just how caregivers made these preparations and to see whether this complied with the manufacturer's instruction. Data analysis there depended on the part of the study. The results were quite surprising in that despite the fact that the WHO, based on the expert panel, said flexible solid dosage forms or dispersible tablets were the preferred liquid dosage forms for children under 5 in low and middle income countries. These participants, over 100 of them, 148 participants, said no, we actually do prefer the liquid dosage form, and they gave reasons for their preference. Now, this didn't matter whether the child was under 2 years or age 2 to 5 years, and it didn't matter whether it was in the outpatient setting of the hospitals where we did a survey, or in pharmacies, or whether the child was actually on a hospital bed. So the disease condition was irrelevant. And patients said, consumers, in this case, the end users, the caregiver said, yes, we find the dispersible tablet easy to administer, but we prefer the liquid dosage form. The second part of this study that was really structural observation focused, referring to the preparability, we could not do. Why was that? On the field, we found out that because the setting was HIV/TB hospital setting, the hospital administrators thought it best not to proceed with this aspect because of issues of sensitivity in my part of the world where the setting, where the study was performed. This second study is actually a protocol, and it is based also on the need to generate evidence to inform policy. A friend of mine at a development agency told me something about their concern about how well mothers are preparing dispersible tablets, preparing oral suspensions for children. So if we're familiar with that, antibiotic preparations usually come in a bottle of a powder, and then you mix according to certain instructions provided by the manufacturer. So he said there is some concern that poorly reconstituted oral antibiotic suspensions might lead to antimicrobial resistance. And we said, okay, let's take this on. So we got some students to perform a quantitative experiment in the lab where they deliberately over-diluted the suspensions and then assayed for quality, which is a measure of assay for potency, which is one measure of quality. So that is the background to this protocol. The results of that is not published, but we did find some interesting results that in some cases, over-dilution by 10% rapidly decreased the potency of the preparation. So now, these are students working under very controlled conditions. How does this play out in practice? So the question here is, do carers comply with manufacturers' mixing instructions? And the aim is to describe reconstitution of mixing and also additionally used by carers. Again, the locations are clearly stated there. For this protocol, you can see there what the checklists are. So these are defined based on what the manufacturers recommend as to how suspensions should be reconstituted. The essential part of this is, do the carers shake the bottle before administering? Do they rinse out the measure after dosing? Because these are important in terms of the amount of antibiotics measured. The other items there will be quantitatively analyzed. More generally, it has been proposed that structured observation, either as a standalone study, or as we've seen from the previous examples, as a component of other studies designed to generate evidence to guide policy or use, proceeds in 8 steps. These 8 steps are listed here sequentially, but there could be changes in order. The first step is to assess the need for resource person. Now, this step is very important for 2 reasons. One is that you need someone to give you an understanding of the context, to understand what challenges you might face in the field, like we saw in case number 1. Secondly, at this point, you need to consider ethics, what you need to do, how long it will take, etc. Informed consents, patient information leaflets. Even though for a study like this that is not strictly clinical, where you don't have to administer any intervention, you need to make sure that the patients understand, or the participants understand what it is they need to do, and that they are voluntarily deciding to take part or not. Secondly, you need to decide also in advance what are the events that you need to measure, and then accordingly design your checklist at a subsequent point. Selecting observers, of course, the observers will need to be capable of performing the survey, despite the fact that at some later point, you might need to train them on how to, on how to perform the observation using the guides that you've developed. So training is an essential component of this. We had mentioned earlier of the need for the location to be as natural as possible. In some cases, this might not be feasible, like we used in the hospital setting as a proxy of what might actually take place in the homes of the participants. Hopefully, in this case number 2, the protocol, we might be able to, in certain instances, observe how they prepare the medicines at home after taking the information from pharmacists in the community pharmacy. And then the last 2 steps, you perform your observation using your checklist and analyze your data according to your research question. So these are essentially the 8 steps. You can find more detailed information in the reference that is applied that is given at the bottom of the slide. So what are the implications of the structured observation as a research method? 1, observations provide valuable information to complement survey or other qualitative or quantitative data collection. And as we saw from case number 1, it is important to integrate acceptability. So now this is the patient's perspective and context or the setting early on in product design. Importantly, for dispersible tablets, which are actually in conditions where there is poor access to power, and considering also that liquid dosage forms, from a formulational perspective, contain a lot of excipients or ingredients that could be harmful to a young child. Dispersible tablets or similar flexible dosage forms are actually preferred, but you need to design education programs to create awareness in the end user to promote the use of this dosage form. And importantly, you need to understand your study location. For the sake of time, I will end here. Thank you for listening. Over to you, Hazel.
Thank you very much, Sam. Thank you very much for that presentation. Thank you for bringing the consumer, the final person actually into this, into the equation today. And I think it was interesting how in your presentation, although we were thinking of the end person, the consumer, you were reflecting how actually issues that involve the consumer have to be taken into account at the very beginning of the development process in formulation and clinical trials. So it's amazing how these things sort of are important to look at in the whole continuum. So thank you very much. Thank you very much, everyone. I just want to, before we move to the Q&A session, and thank you for those who posted questions. Please, if there's any more, please continue to post them as we're having this discussion. The hosts, are you able to show us the result of the poll just so we can see who else is in the room at this stage? Hello, are the hosts able to show us the results of the poll at this stage so we can just let everybody know where people are from that are attending this session? Okay, well, maybe the host will get it ready while we're doing the Q&A. Oh, attendees can see the poll results. Okay, but I can't see them. Is there any way we can see them to reflect on who's there in the room? I can see after the session. Okay, all right. Oh, well, at least you know who's in the room, even if we can't see you yet. We're blinded. Okay, all right. Thank you very much. Okay, so let's move to the Q&A session. And as I say, please continue to post your questions so we can have a bit more interaction with the panelists now, the speakers now. So Zana, there's a couple of questions for you. So I'd like to start with you, if that's okay. So one of the questions to you was, can you just give us a bit more information as to what sort of incentives are given to people who participate in the phone surveys? And I suppose this could become part of a bit of an ethical issue as well. Yeah. So please, could you unmute Zana so she can answer her question?
Thank you. Thank you very much, Hazel. Can you hear me?
Yeah.
Perfect. So the first question was about incentives. The most common incentives that are reported in literature are airtime incentives, and that was what we used in our study as well. The respondents received 50 shillings of airtime, or that's 50 cents in US dollars after each phone interview. And in some cases, there could also be money lotteries. So the respondents are told that after participating in the survey, they're eligible for winning a particular cash amount. So they're entered into a lottery to win a particular cash amount. And as I mentioned, there's mixed evidence on incentives. So further research is needed. Some studies report there's no impact on incentives, on the response rate with incentives. Others report a negative relationship. Others report a positive relationship. So that's not fully elucidated, that dynamic between incentives and response rates.
Great, thank you. And as you say, ongoing research in this sort of area, really, because it is sort of more an area, an aspect, sort of method that's been used more. One other question, which I think you covered quite a lot, but maybe you can highlight any particular other areas that you didn't in your presentation. Somebody's asking, what are the barriers to collecting surveys, doing this sort of survey in a rural area? And I know you did mention some aspects and things, but is there anything else that you want to emphasize?
I think, yes, I did cover this quite broadly. The phone ownership and network coverage are the key issues with rural areas. And something else that requires careful consideration is the type of phone survey that is used. So, for instance, the use of the wireless application protocol, which requires internet connectivity, may not be possible in rural areas, or the use of SMS or the text messages may be a challenge if literacy is an issue. So I think with rural areas, you're limited as to the technologies you would be able to employ.
So I think that does emphasize, one of the points you were making earlier about it's important to know your setting, to know your audience, and to involve local people who not only speak the language, but also know the situation and the leaders and local traditional leaders and everything. So I think, you did sort of point to some of those key things which are very important about doing research in all areas, particularly rural areas. And then just one other point for you, Zana, and I'm also quite interested in this as well. It's what is, I don't know if you know the answer, but maybe you can give us some indication. Have you got any information about the cost involved per participant? I think taking into account that maybe it could be cheaper, or because you're not having to go in person, or maybe it isn't cheaper, I don't know. Because, yeah, and I did notice that actually you do say that 10% are then surveyed, in person. So that seems quite a large number to me, but I don't really know much about the methods myself. But can you speak about that a bit?
Sure. So the study had a benefit of having both in-person interviews and the phone surveys. So we had in-person interviews at baseline, midline, and endline points. And for the household participants per interview, the in-person was approximately $180 per interview. And with the phone surveys, each phone interview to the household respondent was approximately $17 per interview. So there's quite a big difference.
Yeah, that's very interesting. Yeah, thank you. So I'll leave it for there, Zana. If there are any more questions, we might get back to you, but thank you for just giving real insights into that particular method, and and some of the challenges that you've been overcome, and also some of the work still to be done, actually. Thank you.
Thank you.
Sam, I've got a few questions for you. Sam, are you ready to answer a couple of questions? So I think a couple of things that people have been picked up on, which isn't sort of unsurprising, and you did touch on some of them, is around the ethical issues around conducting consumer observations. Can you just tell us a little bit more about how in this particular methods you ensure that ethical issues are addressed with the consumers?
So first of all, one of the things we did, because the primary location or setting for the study was a tertiary hospital, before even conducting the survey and plan observation, we included the staff members of the hospital. So we had the chief pharmacist, we had the chief pediatrician, and we went through the process. So we got feedback from them on what we needed to do. And in that case, we sort of built a rapport between these key players and also the staff members themselves who attend to these participants. So there is this, they call it a APIN clinic, where patients with the HIV/AIDS could collect their medicines at regular time periods in a month. So the staff members at that point sort of served as gatekeepers for us. So we tried as much as possible to make sure that everybody was on board. Now, what that did was that we were able to subsequently create some rapport with the participants that made them, despite the fact that there are all these issues about sensitivity involved, made them a little bit more willing to participate. Now, you could argue that, but they had no choice anyway, because they needed to get the medicines for free and all that, and they were just used as something. So we said, okay, based on advice too that we were given, we gave them, like Zana did in her case, we gave them packages of Indomie. Now, this was low-cost incentive to make it make them a little bit more willing. And because there was nothing more than asking them questions, we felt there was no very serious ethical concern in this case. The additional point where it would have been very difficult was when, we now said, okay, we wanted to ask them to actually reconstitute these suspensions. And then the hospital member said, maybe it's not appropriate. So I guess there will always be the ethical challenge of what to do and what not to do. But I think the central focus of this kind of questions, ethical questions, is that you should first do no harm to the patient, and you should also consider their own voluntariness of the service. So we made sure that this was carried out to the letter. We gave them the opportunity to give verbal consents. We couldn't do written consents.
Okay, sorry, carry on, sorry to interrupt you.
We couldn't do written consent because not all of them were literate, but they did give us verbal consent here.
Okay, and just one other follow-up question then. I know it is tricky with observations. One other follow-up question, which is again another one that often comes up. How do you ensure that people didn't change, or do you think people, change their practice because you're watching them? That's another tricky thing with observations, isn't it?
Yeah, I think that's.
How did you get around? How do you get around that?
Yeah, I think that
sort of work.
I think that's an inherent flaw in the methodology itself that's hard to solve, and therefore you might also need to design other means of overcoming this. Now, the ideal thing perhaps would be to observe this behavior, like we saw with the picture on the slide, to observe this behavior without the participant being aware. That also has some challenges, I guess. So, yeah, I guess it's tricky. There is no simple answer to that. I think you just need to do it in such a way to understand, yes, there's an inherent bias, and then you see how you can design corrections for that.
Yeah. Thank you, Sam. I just want to move to Rafaela now. Rafaela, incentives is something that's, please could you unmute Rafaela, the hosts? Rafaela, incentives is a thing that's come up a few times already in these different presentations. Can you add something about incentives from your study? Were there any incentives given to people who participated in or agreed to participate?
Thank you, Hazel, for the question. Indeed, our setting is quite different, and I would say that the pharmaceutical distributors, which were originally audited in what became this research, they have a kind of incentive because they hope that if they are approved by the auditor, they could gain a commercial opportunity. So in that sense, we have a double reason for protecting their confidentiality. One is the classical confidentiality reason in research. You want to respect the privacy, confidentiality of individuals and of their organization because you don't want the bad rumors comes around about them. But the other one is also to ensure that no participant will use our study as a way to self-promote commercially, which would be also be inappropriate. So this is quite interesting. I think it's different when you have participants, individual rather than institutional participants. Related consideration is that the more the biggest the group which is asking for this quality check, the more we will have an extra incentive outside research to upgrade pharmaceutical standards. Now we have these distributors who knows if we are doing well with this kind of evaluation, we will become possible supplier of this group of NGO or of this group of supply of purchaser in Africa. The more people are applying these requirements, the more we have a commercial incentive reinforcing the regulatory incentive to improve quality systems. So this was also a kind of side findings of the research. Thank you for asking.
Yeah, no, that's interesting. Yes. And yes, Rafaela speaks as someone who has a lot of experience in ethics. So it's great to hear you on that one in particular. Really respect those comments, especially for that reason. There's a couple of questions that were posed to me on behalf of Non-Demiso. One was somebody asking about, could I explain the intervention if we're talking about methods to measure and methods to improve perhaps medicine use. I can just give briefly, just to say that it was basically what's sort of known really as audit and feedback. So Non-Demiso went to the selected facilities that were part of the intervention, that were randomized into the intervention, and did a preliminary look at some prescriptions over the past, well, she would probably correct me, but just roughly over the last month, and then looked at what some of the issues were, quickly analyzed them, and I think it was about 20 or 50 or something, 30, quickly analyzed them, and then had like a feedback meeting with the staff who were in the facility and discussed some of the key issues there. So it was more like an audit and feedback sort of process. Although obviously I couldn't explain it as well as she could. Somebody else asked, were they all primary healthcare level facilities? No, they weren't. In her study sample, she excluded a couple of the tertiary settings in Eswatini, obviously not many because it's a smallish country. She excluded some specialized clinics, such as those facilities, those in the military or particular disease conditions. And mostly the rest were included. So that was mostly PHC facilities, primary healthcare clinics, nurse-driven clinics, some what she calls community health centers, where there were doctors and pharmacists present. And then there were a few tertiary secondary hospitals as well. And so in her study sample, selected sample, she actually selected a secondary hospital, I think, from each region. So there were 4, and then the rest was clinics and primary healthcare. And she did do analysis in looking at the differences between secondary and primary as well. But because the numbers were small, again, it was not so easy to draw conclusions. There was another question about were there specific indicators that were used for NCD medicines, to measure NCD medicines? Well, not specifically. She used the INRUD indicators and just identified those that were medicines for non-communicable diseases. She didn't, in her study, develop any specific indicators or use any specific indicators for NCD medicines. So I think, to the best of my ability, those were the comments, feedback from the comments to non-do. I'm just looking to see if there's any more, and maybe that's all of them. There's another question. I think it's to Sam, but I'm not sure actually, or it could be to Rafaela. In the context of quality of medicine, how do we minimize the effects of asymmetry of information between consumers and healthcare provider? Who would like to answer that question? I'm not quite sure if it's to, oh, okay. Well, actually we'll have Sam and Rafaela because you're probably going to give slightly different perspectives. And if you want to join in as well, Zana, you can. But let's have Sam first then. In the context of quality of medicine, how can we minimize the effects of asymmetry of information between consumers and healthcare providers?
2 words.
Sam first.
First of all, awareness. Secondly, empowerment. I'll expatiate. Nigeria ran a very successful awareness creation program for consumers. They called it Operation Shine Your Eyes, where consumers were asked by the Drug Regulatory Authority to demand at medicines outlets and pharmacies proof that the medicine is registered with the regulatory agency. This awareness was so great that consumers would not buy a drug from any medicine outlet unless they saw that number. So this is the importance of creating awareness and empowering consumers. The second part of it refers to the use of technology. So there are what they call medicine authentication services. In my part of the world, you have a number on a pack of anti-malaria, for instance, and then the consumer scratches off the covering to reveal a number that the consumer can dial to assure the quality of the medicine. So very quickly, these are 2 ways to address this asymmetry of information between consumers and healthcare providers. Thank you.
Thanks, Sam. And that really just emphasizes the importance of using advocacy, doesn't it? I suppose as another sort of method really to get information to consumers about medicines and important issues. Yeah, and then that gives a whole lot of other methods actually of how do we get that information across to people. Great. Rafaela, over to you. Please, could you unmute Rafaela? Ah, thank you.
Okay, it's done. But of course, I was happy that Sam replied first, so I only have to compliment his perfect answer. I think we just add a few things, perhaps also add really advocacy, like there has been a lot of advocacy by patients association in the past and by community for access, for financial access to some innovative medicines. So the same capacity to join forces to advocate has not been brought together yet for quality assurance of medicine. So perhaps we have to also to work on that. And I think that's where research comes in, the research of some of also our research, for instance, the findings that the cold chain management is still so poor. So you can really have an impact on insulin, on vaccine, on oxytocin. Of course, we can advocate, but if advocacy is substantiated by research findings, it becomes stronger. And this is what you mentioned in the beginning, Hazel. Why we are here is to say with research, we can really get also to translation into policies. So this is one of the ways where our research can be translated into advocacies and into policies. I just also wanted to add a third actors here, also asymmetry of information. For some of the suppliers, one of the findings of one of our study was that particularly purchasers in Africa, particularly actors working in central medical stores in some sub-Saharan African countries said, we don't have the information from some big suppliers, some important manufacturers consider us as small actors. Our purchase is not that important in financial terms. So sometimes we are just struggling to get a complete medicine dossier. We ask for the proof of bioequivalence, we ask for the proof of stability studies. We don't get the accurate information. So there is also a need to join forces, because sometimes a small purchaser, even if it's serving public health, can be considered not sufficiently interesting from a commercial point of view to share with them all the information.
So these are the important aspects that get highlighted through the sort of research you're doing that have, you know, policy implications. Yeah. Zana, do you have anything to add on the thing about asymmetry of information? No. I don't see any more new questions, actually. I don't see any more new questions, but I've just got a question myself to ask you. You know, this we're currently in the COVID-19 sort of crisis, and we're still in it, and some more than others, depending where we are in the globe and what season. But how do you think the COVID-19 sort of situation has highlighted sort of the strengths or weaknesses of your particular methods? So maybe that's just something for you to think about, and whoever would like to. Maybe I'll ask Zana first, because you hadn't spoken for a while. Can you unmute, please? Can you unmute Zana, and she can answer the question?
Oh, yes. Okay, so thank you for that question, Hazel. I think the method that I presented on its utility is extremely evident at this time of COVID-19, with the limitations with movement and the requirement for social distancing to minimize the spread. I think the use of phone surveys for data collection would be extremely useful, not only because of the benefits that I highlighted around it being cheaper and being less, more able to reach inaccessible areas, and the flexibility with language as well. I do think that, and the phone surveys in these times of COVID to ensure that research continues is extremely important, particularly research related to COVID-19, as far as collecting timely data. And it has been used, I believe in Kenya, the phones have been relied on by the Ministry of Health to monitor people who have tested positive for COVID and are isolating at home, for example.
Thank you. So yes, so in a way, I think your method really does lend itself to being able to use in this time. And I know from my own experience in our university, you know, quite a few people who were expecting to do in-person interviews or visit facilities actually changed to phone surveys. So I think, yeah, going forward, this method is probably going to be used even more, actually. So I'm sure the learning from this time will actually contribute, you know, going forward as well. Yeah. Thank you, Zana.
Thank you.
What about Rafaela? You're unmuted. What are the sort of learnings, not just for your method, but maybe some of the issues that you're looking at with regard to quality?
I would say when it concerning our methods, of course, we have this problem that our source data basically comes from in-person physical inspections. So when we come to a world where travels are severely restricted, where we have confinement, where we have basically the impossibility to send auditors around, what will we do? We are facing a situation where it is important to get rapidly assessments of new suppliers, of new products, because things are coming rapidly, but we cannot travel there. And we have built a full system about, about travels. So the first important issues to address is to try to see to what extent minor evil, like an audit conducted remotely through an online platform like Zoom, for instance, now could still provide sufficiently reliable information. Of course, nothing can replace the fact of being there and looking into papers and looking at how a machine is operating, but perhaps we can get something also remotely, which is better than nothing, even if it's not the best, the gold standards. And I think major regulators are already looking into this, but then the researchers could bring the added value of helping with validation of methods, with helping with internal consistency, etc. So I think this is really the most important challenge at the moment. Being very, very careful, because I think it's Hannah Arendt who must have said that people forget rapidly when they went for the less evil. So whatever we can validate now in terms of remote audit methodology, it will not be the gold standard. It will be something which can approach the gold standards and be used in the situations, in emergency situation like this one.
Great, thank you. Yeah, I think this, it does, but this situation does make us think about what we can put in place at times when there wouldn't be able to be in-person stuff. So, and I think it's interesting what you're saying, that, people like yourself working in this method can actually contribute to other policymakers and such as regulators and things like that, and regulators and things like that. So that's also an interesting outcome that could go forward. Sam, what about you? Your consumers' observations, they could be a bit curtailed, I think, with COVID, but I don't know.
Yeah, definitely. I mean, where there are travel restrictions, this won't work. But in cases where there are none, for instance, people, excuse me, may still need to go to the hospitals. And for those facilities, for people who can still go for routine medical tests, one way perhaps in these very challenging times might be to leverage the existing prescriber-dispenser relationship with the client. So for instance, in Nigeria, people still go to pharmacies, and you could use that as an opportunity. I mean, if the essence is explained to the client as an educational program where the patients benefit from this observation, followed by an intervention aimed at correcting any wrongly observed steps, then it's a win-win situation. The patient gains, and you conduct your study. A second approach might be, especially in my context, home visits by close family members. Again, the idea is that the person is trained, sufficiently made aware of the right protocol or process, and can provide information to the participants. But of course, in both cases, there are caveats, like we see with many things related to COVID-19.
Great, thank you. Yeah, I think as regards observing people, it's going to be quite difficult in person through this time. But yeah, I suppose there could be some things put in place, like, instead of face-to-face training, then you can use sort of mobile platforms maybe for some population, but definitely tricky. Just to reflect from non-DO study with the quantitative and qualitative methods and the intervention. Well, for the quantitative data, initially she used the registers from the facilities, because that's how the data was compiled. Over time, in fact, during her study, they started using an electronic database. And so going forward, it would be possible to do the quantitative aspect of her study just using an electronic database. So again, that's something that would be flexible and available to use during a crisis like this, and avoids traveling to facilities. Obviously, the qualitative interviews were face-to-face and the intervention was face-to-face. Of course, it would be possible going forward to do some telephonic interviews, but obviously I think she would feel that she would miss out on some of the non-verbal sort of cues, and yeah, and so it would be more difficult. So yeah, I think it's safe to say that in her situation, the quantitative could still carry on going forward with electronic data, but the qualitative would be more difficult, and actually doing an intervention would be more difficult. And Rafaela just wants to say something on this, and then I think after that we will just see if anyone else. So Rafaela, can you make this comment, and then any other final comments from you? as a wrap
Yeah,
up, and then we'll just go
thank
around
you.
the others.
I think, no, I just wanted to add a more general comments, which I think is probably common to the four of us. With the rapidly evolving pharmaceutical scenario with COVID-19, it becomes difficult to know which are the research priorities. I think all our methodologies can be adapted, but then with the status of some repurposed medicines is changing so rapidly, and it becomes even difficult from a researcher perspective to stay up to date with all the scientific literature which is going out. So I think that now, for instance, for our perspective, the question would be really to say, okay, but where do policymakers needs more guidance now? What are the products of the which are likely to be important in 6 months from now, which we should investigate? I think this is a big question mark in this during these pandemics, and I only have the question and I don't have the answer.
Yeah, but it certainly promotes us to think that way.
Yeah. And I think for my conclusive remarks, firstly, I was amazed to share to watch the presentations of the colleagues, and I was now thinking of a number of ways where we could build research together by combining the different views. We have views at healthcare level, we have views at consumers level, we have views at providers and suppliers level. So to look at these things together would really help us to have a better understanding of the scenario. And then for Hazel, you know me, you know that this is my personal obsession, but I think we really show that it is possible to make a bridge between pharmacy and public health. Pharmacists, we were almost all trained as pharmacists, and people think we are the technical people busy with the warehouse. And indeed, medicines are so important in health systems. So all this finding of research can be really translated into policies, and we have to find a common language between these two levels to make this more often.
Thank you, Rafaela. That's a very nice way for you to sum up some of the key aspects of this session. Sam and Zana, I just give you the opportunity just to add a couple of roundup comments, if you'd like to. Zana, should I say you first? Zana, please, can you unmute Zana?
Sure. Thank you very much, Hazel. I want to thank everyone for joining us today. I really enjoyed participating in this session and learning from my colleagues as well. It's been a very interesting session that just shows how multifaceted the area of medicines and medicines research is. We've touched on quality, availability, affordability, and acceptability as well. And I'm relatively early in my career as a pharmacist and a public health researcher. So this does definitely add very many questions into the systems that are present, particularly in view of the COVID-19 situation, which is changing. I'm particularly interested in seeing how the use of phone surveys in this time lends itself to learning more about this method. So overall, extremely interesting session, and definitely looking forward to participating in more of this conference as well. Thank you.
Thank you very much, Zana. Sam, for you, the last few words. Please, could you unmute Sam?
Yeah, I think I just simply want to recapitulate what Rafaela said and to provide some more information. So I think I like this idea of an integrated whole. So it's a whole chain, starting from producers to the consumers, and that needs to be factored in when we talk especially about medicines quality. And I think, Rafaela, you will know, and as well as the participants, that currently in the midst of this global challenge, we're seeing increased incidence of falsified, mostly falsified chloroquine tablets in Africa and even in some parts of France. So I guess, we may continue to see increases like this with antibiotics and antimalarials that are quote unquote, effective for COVID-19. So I think this proactive watch by all concerns, be these pharmacists in Africa, be these hospital staff, pharmacists as well. I think it simply sends a signal that we all should be forward watching and alert. Thank you.
Thank you very much, everyone. Host, could we just have the last slide on, please? The one with medicines and health systems information. Oh, before we go, we've got a poll. Thank you very much for showing that. So we have 17% are already medicines and health systems members. The region they're from, mostly from Africa, 36% from Africa and 28% from Southeast Asia. Wow, that's amazing. And representatives from all the other regions. And then which sector represents you most? We've got mostly nearly 30% from non-governmental organizations. That's interesting. 15% from government, 43% from universities, known from regulatory organizations. Rafaela would, and disappointed to hear that, but maybe not unexpected. Thank you very much for showing us that information. We will use this going forward in our further work. So thank you very much, hosts. As a wrap up, I just want to say how much we've appreciated having the opportunity to present this session to you. Like I said at the beginning, it was a little bit different than we envisaged, but nevertheless, we're grateful for the opportunity Health Systems Global has afforded us. At the end of each of the presentations, speaker presentations, you do find the contact details of the speakers, as well as throughout the presentations, some links to papers and key publications that are useful. So we hope that you will look at them going forward and contact the individuals and look through the publications to learn more. Just two other final announcements before we go back to the, have this slide to go back to the platform, is that we really do want to encourage those of you who are not medicines and health systems, who are not part of the Medicines and Health Systems Thematic Working Group, to consider joining us. The link at the bottom of this slide links directly to our thematic working group, and there's information there on how you can join. I think what we'd like to say is that although you probably are part of Health Systems Global if you're attending the conference, even if you're not part of Health Systems Global as a member, you still can join our thematic working group, and we do encourage you to do that and encourage other colleagues who would benefit from being part of the group. We have, and then you can find out more about us, as I say, on this through this link, and you'll see we have webinars, newsletters, etc. And we hope that depending on the interest, we may be able to have further webinars on these sort of topics that have been covered today. And then just to do a final plug for our thematic working group session, part of the Health Systems Global Conference. It would have been in the conference in Dubai, but of course not everything, no, it's not happening now. So our thematic working group session will be part of phase 2, and will be between December and March. And I'm sure at some stage later on, you as conference participants in phase 1 will be notified of when this session will be happening. And we really would like you to encourage you to join us at that session as well. So that's all from me, and I really want to just give a final thank you to our speakers this afternoon, Rafaela Ravinetto from Belgium, Zana Kiragu from Kenya, and Sam Aruba from Nigeria, and also thank Nondumiso Ube from Eswatini. So thank you to all of you for putting this session together, and thank you very much to the hosts for facilitating the session, for and taking us through it. Thank you very much indeed. And thank you to all of you who've attended yeah, we look forward to hearing from some of you individually. Please contact us directly. Thank you. Bye-bye.